Go for it, Anna.
Okay, so I will present a newborn baby, a term newborn, that in the 26 hours of life, he had bilirubin levels above exchange transfusion. He was given immunoglobulin and started intensive phototherapy. And on the day 6 of life, I was on the unit and went to do head ultrasound. It was a baby with a isoimmunization from group B. I have this ultrasound machine in my unit. It's a GE Vivid 770. I use a microconvex probe with the cranial ultrasound settings. Starting from the front in the coronal views, we have the interhemispheric fissure and the frontal lobes and the orbits. Everything seems good.
Yep. Nice frontal blush there. Very nice orbits. Yep. Perfect.
I'm having a little bit of difficulty moving the slides on. Sorry.
No, take your time. No problems.
Then going back, I think we can see the ventricle here, but I think this is not symmetric, you know,
Yeah,
because
absolutely.
there were no enlarged ventricles in the other views.
Sure.
So I think this is not a true image. Going back, we had a surprise because we can see that ventricles are with the blood inside. So it seems like intraventricular hemorrhage here.
Yep.
And keeping going back in the plans, we see that the blood is inside the ventricles, both ventricles.
Yep.
In this plane, we can see the choroid plexus. It seems maybe a little bulky on the left side.
What gestation was your baby again? Just remind me.
38.
38 weeks. Okay. Yep.
Yes, it's a term baby.
Yep.
We were not expecting this when we started doing the ultrasound. And here is the left coronal plane with the parieto-occipital lobes. And I think the left side is a little bit more bright, but there is other images where we can see it.
Sure. Yep.
Starting with the sagittal midline, we can see the corpus callosum, the third and fourth ventricle, and the cerebellum.
Yep.
And going lateral to the right, we can see that the anterior horn of the ventricle is full with the blood.
Yep.
And it seems that maybe it's a clot in the occipital horn too. We were in doubt about that, but all the frontal horns are full with blood. And the left side, I think I'm going back. I went back. And going more sagittal with the tangential one, we can see the fissure of Sylvian fissure with the branches and a little bit of echogenicity that I think it's normal in the right side.
Yep.
And on the left, okay, I'm moving back. Okay. On the left side, the same thing on the right with the frontal horns with blood. And going more sagittal with the Sylvian fissure, I think this is a little bit asymmetric comparing the right to left. I think left is a little bit more echogenic.
Can we go back to your right image, just if it's possible?
Yes, so if I can Is it okay? Okay,
Yep.
this is right.
Yep.
Oh, the other one.
Sure.
And here is left.
Yeah, it does look a little bit more echogenic. You're right. Correct.
And
Yep.
in the ultrasound machine, the difference was bigger. And I took the resistivity index,
Point
more for
0.6.
training, but
Yeah.
it's normal.
Yeah.
It does it automatically. It was 0.64, and then I did the manual one, and it's similar.
Yep.
We tried the posterior fontanelle, but
Yeah. It's difficult in a term baby because the fontanelle will be quite small.
I couldn't do the coronal one. I couldn't see anything in the sagittal. We can see a little bit of the plexus
Yeah.
and maybe a clot on the left. We are not sure. Then I could did a mastoid fontanelle, and
Yep.
we can see that the fourth ventricle is free of
Yep.
clots.
Yep.
So it was good to see it. And I think this is my last image.
Amazing.
So
So let's just go back to your coronal image where you can see the IVH. So
okay,
can I ask just
this one,
how old was the baby at this stage?
6 days.
He's 6 days old. And I mean,
Yeah.
clinical presentation, normal baby on the postnatal ward picked up with jaundice.
Yes, only because of jaundice. He went to the unit only because the level was too high for 26 hours. It was 7 above the exchange transfusion level.
So no instrumentation.
It was a no, it was a vacuum delivery.
Okay. And any clotting abnormalities of
No,
nothing.
no.
Platelets
Platelets normal, blood tests for coagulation, everything was normal.
and no infection either.
No infection either. Only the jaundice.
So what would you grade these as, Anna? What grade did you give them?
It's a grade 2.
Yeah, it's a grade 2 IVH, and really from our perspective, I'll be taking it up on the 6th of April. So please don't worry about grades. We'll talk about both the grading systems, but it's quite unusual to find in a term baby instrumentation or a vacuum delivery. Uh, you know, it's uncommon even in those babies to actually have intraventricular bleeding. Having subdurals and having collections outside the level of the meninges is not unusual. Sometimes having a stroke in those babies is not unusual, but to have IVH is very unusual. So, no, I mean, just out of curiosity, what cause are you attributing? No resuscitation needed for this baby, normal
No,
lab
no,
cause.
no, 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 no. The baby was born great with 9, 10 score, upper score. No.
And I mean,
He
from a,
was feeding well, he was doing well. The hemoglobin level was normal, around 17.
yep.
He started drop after because of the isoimmunization, but in the beginning, the level was normal. And I'm a little bit sad because I didn't use the linear probe to see the sagittal sinus, and the baby now is not in our unit anymore because he was not from our area of living, so he was transferred to another hospital. So
So
I
I was
couldn't do
just
it.
going to come to that. I mean, was there any signs of dehydration? Sodium, was that high?
No,
It
sodium
wasn't.
normal,
It was
normal,
normal. Okay.
139. The weight was under, you lose a little bit, not more than 10%. There was nothing pointing there, nothing.
So the reason I raise that is obviously hypernatremic dehydration with jaundice in a baby who's exclusively breastfed or may have weight loss can present with sinus venous thrombosis. Uh, and sinus venous thrombosis can present with intraventricular hemorrhage.
Yes,
often in situations like that, babies are very dehydrated. Doesn't sound like that was the case with your
No,
baby
no,
at
no,
all. Yeah.
no, 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 no.
So it's an interesting, very interesting case. And really, what would be very interesting is to see and follow the baby up. That's going to be a challenge because the baby's left your unit to kind of
Yes,
see
yes.
how quickly it resolves in terms of cystic change. And if you start seeing very early cystic change, like if I repeated a scan in a few days and I started seeing a hypoechoic kind of an area in the middle of those two hemorrhages, with
Mm-hmm.
because what you can see is this is not really very echo bright. So because it's not echo bright, it's nearly isoechoic to the ventricular margins, which kind of makes me feel that this bleed has probably happened a while back.
Old.
The
Yeah.
only other thing that I would say is your Sylvian fissure on this side looks quite thick, but I think that's just, can we just go to your midline image? Just keen to explore whether there's any element of asymmetry in the Sylvian fissures. So,
What image do you want?
so
Sorry.
the coronal midline,
This one?
yeah, just this one. So the only thing, I mean, my gut feeling is it's just with the eye of faith, the Sylvian fissure just looks a little bit thicker on that left side. Uh,
Mm-hmm.
but I'd probably say it's not very significant. But there's definitely flare on that left side and
Yeah.
echogenicity that you can see in the parenchyma. So, I mean, this baby, obviously, perinatal compromise with an in utero bleed. Like I said, if you develop very early cystic change, these could be antenatal bleeds. And I mean, almost certainly, absolutely no doubt, this would be a baby who would fit my criteria for doing an MRI. Uh,
Yes, yes, of course. Yes.
so it would be very interesting if they
I'll
do.
try to know.
Yeah, it
If
would be
I
very
if I
interesting.
know, I will inform you.
It's a beautiful case. It's a beautiful case. So Shinza is asking, wouldn't severe hyperbilirubinemia cause IVH by brain tissue injury? It's uncommon. I would say intraventricular hemorrhage. I think if you've got frank kernicterus with a bilirubin of 600, uh, it's actually the cause of the kernicterus that I would worry more about. But simple ABO and RH incompatibility giving you frank IVH is not something that I've seen commonly. A torch infection, or as we were talked, there are lots of infections that can give you IVH, and clearly the history that Anna's given us isn't really very kind of suggestive of that. For a vascular malformation, yes, it's a possibility. But Anna's put Dopplers on and can't actually see a vascular malformation at this stage. And again, what I'd say is there are like a vein of Galen wouldn't give you frank IVH at this age. So, arteriovenous malformations, you'd probably see something pulsatile, something cystic and pulsatile in the brain, put vascular Dopplers on it. So to me, this looks like bilateral grade ones, definitely with echogenicity on that left side. Be very interesting to follow and see whether this evolves into a parenchymal venous hemorrhagic infarct on that left side with time going forwards. And an MRI with an MRV and an MRA would definitely be
Yes.
indicated to make sure that he's not stroked on that left side. Beautiful images. Thank you so much. Do you have
Hello,
another
Thank
may
one?
I
you.
ask one question?
Please, please. Yeah, yeah.
Sorry, but just on the coronal view midline,
Hmm.
there is no hyperechogenicity on the left side suggesting of intraparenchymal, or you will
No,
not
I
consider
agree.
it.
I agree. Not at the moment, no. But the question is when you have echogenicity, following that area up to see how the hemorrhage evolves, and in particular that flare. So at the moment, they're completely separate. But sometimes you can stroke, develop a venous infarct secondary to a sinus venous thrombosis, and that can evolve into a PIVH on that left side. So again, the sagittal sinus, taking a linear probe and looking at the sagittal sinus in this case to see if there's actually Doppler flow in it would be helpful,
And
as well as, yeah.
on this view also, there is no patch of hyperechogenicity
I
on.
think if you kept the right and the left views side by side, you'd be able to determine that there's a little bit more echogenicity in the left side. Let's go back to your coronal view, Anna. So your coronal midline. So can you see that area there? S- Can you see the flare on that left side? It's definitely more echogenic. Uh, and this is even with the dropout, I would just worry about the flare on that left side. I definitely want to follow it up. Absolutely no doubt about it. But this is not a grade 4. No, absolutely. This is just intraventricular hemorrhage with flare more on the left than on the right side. The echogenicity for me on the left side is a little bit more marked. I'd definitely be following this up with an MRI.
Thank
Do you have another image, Anna?
No, that's
We've
all.
we've got some really people. It's a fantastic case. Thank you so much for sharing it. Just
Thank you.
makes you
I
wake
want
up.
to ask I want to ask a question. It's
Sure,
okay.
Nigrushu. Yeah, go for it.
For Anna, it is not routinely done an ultrasound of baby at this age. What made you consider doing this investigation? Do you
Just
have
because the bilirubin level was really high on 26 hours of life.
and you
So
do
we
for
do
all the baby who have this level
with the
ultrasound?
transfusion level, yes, we do it. It's routine in our unit, yes.
I thought you will say this. That's why I asked.
Yes, we do it in babies with these levels of bilirubin. We usually do a ultrasound, a cranial ultrasound, yes.
Okay, thank you.
Any other questions, Fana? Okay, fantastic. Patricia, would you like to share?
Yes.
Sorry, what would you be looking for if there's hyperbilirubin to do a scan?
I think personally, I think if I've done an exchange level kind of exchange transfusion, my personal view is if neurology is completely intact and normal, probably a screening ultrasound is all I'd be doing. It's not going to show us anything if the neurology is normal and we're not suspecting acute bilirubin encephalopathy. But if you have acute bilirubin encephalopathy and you have a baby who's extremely sick, then signs of cerebral edema, slit-like ventricles, brightness and flare in the periventricular areas, depending on whether there's ischemia. Again, looking at the watershed areas very carefully, just to look for echogenicity would be quite important. That being said, I think if I want to make a diagnosis of connectress, I would be going straight for an MRI. It would give us a lot more information. You may well, after a few weeks of having had the hyperbilirubinemia, start seeing basal ganglia and thalamic changes, chronic changes, where again, you see what I would say is hypo and hyperechoic kind of differentiation. It needs a very, very good resolution on your probe to be able to do that. My experience is it's just better to get an MRI done in those babies. It's better for prognosis as well, if you can. So Patricia, go for it.
Can you see? Oh,
I can see your slides. You're audible and visible.
oh, brilliant. Okay, so I'm new to scanning, and I did a supervised scan with a curvilinear probe on, I think it was a GE scanner.
Yep.
Okay, so I have a 28-week and 1-day gestation baby who had was born by cesarean section for absent end diastolic flow. The baby needed one set of inflation breaths and required up to about 50% oxygen. It was then titrated down to about 30%, but baby had an increased work breathing, was grunting, recessing. So the PEEP was maintained. The baby on the neonatal unit was started on CPAP, was intubated and ventilated. We gave a surfactant called Curacert, commenced antibiotics. The first cranial ultrasound scan that was done was normal. And this is the scan that I attempted.
It's beautiful. It's absolutely
So,
beautiful.
the first one with the lateral ventricles, and I think you can't really see the is that the corpus callosum over the top there?
Yeah,
And,
that's correct. I can
yeah.
see it. I can see it very well, and I can
And
see it right till the anterior.
the
Yep.
fourth ventricle,
Yep.
and the cerebellum at the back with the vermis here. Then going on to the second scan, we have the caudothalamic groove, and what else? The choroid plexus, I think.
Yep.
Yeah.
Perfect.
And then the last one with the, well, you can't, I don't think you can see the Sylvian fissure that well, but in the insula,
I can, yeah, I can see the Sylvian fissure. It's a very nice image. The temporal lobe is the only thing that we missed out on a little bit, but it's a beautiful image. Look at the blush. It's beautiful. And it's normal blush. Very nice. Very nice images.
Right. And so I didn't actually do the other side. I went on, well, I did at the time, but went on to the coronal images. So the first one with the anterior to the frontal horns, the lateral ventricles, and we can see the orbital ridges. The interhemispheric fissure I felt could have been a bit clearer, but
it's perfect. You've got a nice image. You can make a perfectly reasonable interpretation from it. Absolutely no complaints. Well done.
And the second one, I didn't really get the cavum septum pellucidum, but again, the frontal horns of the lateral ventricles were visible.
So just be aware that when you go for your second frontal horn image, it may not be visible, and it might actually start becoming visible further on. And I'll explain that when you will go back to your sagittal views, but carry on. Yeah, beautiful images. Beautiful.
And then at the third ventricle, it's just visible down here.
Very nice. Very nice.
And then I'm not sure whether I've done sort of a similar image twice, but
no, you haven't. You've actually been able to demonstrate, and it's just fantastic. I'm gonna take the opportunity to stop you there because this is an image, especially for those of you who are starting to basically do images. You've basically got a midline image where you demonstrate the cavum and the third ventricle. So this is the third ventricle, that's the cavum, these are the lateral ventricles. And then as you go further back, you get an even more beautiful image with the foramen of Monro, which basically is communicating with really your third ventricle over here. So it's absolutely beautiful. And sometimes what happens is it's just minor movements of the probe. You've got the corpus callosum here. You've got a beautiful interhemispheric fissure. These are absolutely amazing images.
Okay, and then I think, yeah, probably a very similar image here.
Yep.
And then my fifth image here with the choroid plexus, which is a little bit uneven, but can still see that. And then the back
occipital lobe, yeah.
With the posterior to the choroids. Yeah.
Very nice. Very nice. These are beautiful images. You've got really good gain. So let's just go back to your midline image sagittally. So a very nice image. And really from your perspective, you can see the anterior, the cavum septum pellucidum. Towards the back here, you've got what is called the cavum vergi. So I'll just outline it for you. So this is the cavum septum pellucidum, and this is the cavum vergi that you see at the back over here. Interestingly, it disappears. It's very small. It's just a remnant at 28 weeks in this baby, so it's not really well visualized when you go to the posterior views, but very, very nice. The depth settings are perfect. You've utilized your probe. Your image fills the whole of the screen. So very good images. My only comment is your gain settings are just a wee high. Are you using the auto gain function?
There is a knob to actually alter that, so I can reduce it slightly. Yes.
Very slightly. I'd probably one of the things with the images often is it will tell you exactly what percentage of gain you're using, just marginally. That's it. But the images are beautiful. Well done. Have you got another one?
I could probably find it, but my technical assistant has actually gone, so
no problems. No, I understand.
I'll do that another time. Yeah.
No problems.
Thank you, Alok. Thank you.
My pleasure. Beautiful images. Dr. Hasoon, are you going to present today?
Look, I apologize because my PowerPoint not working now. I
No
don't know what
problems.
happened, but can I present for the next session?
You can present for the next session.
Okay,
So
thank you.
anybody else have any that they want to present? Otherwise, we've got a very interesting topic to cover today.
I stopped sharing. Sorry.
No problems. Take your time.
So I'm not sure how to stop sharing it now.
I will be able to do that. You just give me a moment. I will just bring up my PowerPoint. So can you see my PowerPoint presentation?
Yes,
And is it now full screen?
it is, yes.
Okay. So I'm going to talk to you a little bit about cranial ultrasound and neonatal infections. And really what I'm going to cover today is mainly bacterial and fungal infections. We will, in due course, also cover certain viral infections. In particular, herpes is the other one that I would like to cover, but I'm not going to cover it today. I'm going to give you a little bit of an overview from our perspective of really how cranial ultrasound is used as a neuroimaging modality in babies who develop sepsis and meningitis. And in particular, what I would like to do is give you a little bit of a flavor of really the different organisms and patterns that we see with neonatal infections, in particular central nervous system infections, where we have positive bacterial and fungal cultures. It's also very important because a lot of our management may really depend upon serial ultrasound imaging, especially if that baby goes on to develop hydrocephalus, or in particular, if we see ongoing signs of, I would say, meningitis on scans, which might not be responsive to antibiotics. It may be a very good way of really looking at your response to treatment. That being said, there are limitations to cranial ultrasound that we must accept. And one of them, obviously, is the ability to delineate lesions with, I would say, a high degree of sensitivity and specificity. And that a lot of babies, in particular preterm babies with infection who have got IVH and have got other comorbidities, can really give you very similar kinds of findings. And in term babies, some of the findings that we find from an infectious etiology causing them to become unwell causes problems which mimic other conditions like stroke-like syndrome, like parenchymal venous infarction, parenchymal arterial infarction. And really, the most important aspect of using cranial ultrasound in this context is you have to clinically correlate. So when we talk about bacterial infections in particular, they, occur in about zero point 0.3 to zero point 0.5 per thousand live births. So if you look at, I would say early onset sepsis, the incidence is about 0.5 per thousand live births. And that really, from our perspective, varies from unit to unit. I think if you went to India, you'd find much higher incidence. Again, the incidence in the UAE is a little bit higher than the incidence that I've seen in certain units in the UK. And that really is based on local flora. Again, we have a higher incidence of having gram-negative infections. While GBS is still one of the most common organisms in the UAE, we do see a lot of E. coli and Klebsiella with, I would say, the population here. In the UK, the dominant organism still tends to be Group B Streptococcus, but we know that E. coli has come up in a big way, and even in national data, we tend to see gram-negative infections starting to become more prominent. That being said, we will rarely, very rarely, in our setup, get rare infections with Listeria, Bacillus cereus, and certain other organisms like Citrobacter serratia, which can really cause quite severe cerebral sequelae and can cause quite severe intracranial infection. When we talk about viral infections, clearly the common viral infections that affect neonates that we commonly see that cause CNS manifestations, well, the most common would actually be cytomegalovirus. The second most common organism I would say that we see in our setup is herpes, and herpes tends to cause a meningoencephalitis. For slightly older neonates under 30 days, you can see a variety of other viruses which include entero, paraco, and rotavirus. But really, some babies may have congenital infection. And of the congenital infections, while CMV is the most common, it's not uncommon for us to see varicella encephalitis, rubella-related changes in the brain, in particular when you see calcification. And Zika is quite, I would say, prominent in certain South American countries. The presentation of herpes is usually as part of disseminated involvement, and it's quite serious and can be, is associated with a high mortality. But I'm not really going to cover viral infections today. I think what I will, however, cover is fungal infections because they can give you very typical ultrasound features. And really, I would say that there is now becoming quite, I would say, a surge in non-albicans candida. And then in the occasional neonate who might have immunosuppression, seeing cases with aspergillosis, it's something very rare. I've only ever seen 2 neonates with aspergillosis in my 2.5 decades of training and being an neonatologist. So it's quite uncommon. But seeing candida, very common, and seeing candida in the brain, I've seen quite a few cases. One case recently. So the most important aspect of kind of sonography in these babies is the fact that really it's based on clinical presentation, and that when you're trying to perform sonography, you will either have a baby who's become acutely unwell with an infection, who's presented with seizures, so has got some neurological kind of features which prompts you to do a cranial ultrasound. Alternatively, you may have made a diagnosis of early onset sepsis or late onset sepsis, and really, in that, you have diagnosed meningitis by doing a lumbar puncture, which may again prompt you to kind of wanting to do a cranial ultrasound. But if you look at the clinical presentation in neonates, babies born in the first 30 days, most babies will either present with early onset or late onset sepsis as per the definition, and they will be quite sick in the early phase. They might have seizures, need for ventilation, they might have hemodynamic instability, commonly with Staph aureus, and in particular with Bacillus cereus. You can see fever as a very common presentation. Other kind of presentations with kind of temperature instability and hypothermia tends to be more common with GBS, which presents with lethargy, non-specific kind of signs. And really, you make a diagnosis of sepsis based on blood markers in addition to the clinical parameters, and then do a lumbar puncture, which helps you confirm your diagnosis of meningitis. Alternatively, the baby may not be stable enough to do that. And in some babies, what happens is we're not able to do lumbar punctures, but really, if they're preterm and you do ultrasounds, you might then make a diagnosis of meningitis on your ultrasound. And we'll talk about some of the features. In the subacute phase, naturally, you're treating a baby, maybe with antibiotics, maybe with antifungals, and really the baby tends to present with lethargy, fever, poor feeding, but can still have neurology in the form of seizures, but more commonly starts developing neurological abnormalities and sequelae. And one of those sequelae is hydrocephalus. If it's really bad meningitis, meningoencephalitis, where you've either had intraventricular bleeding or you've had exudates, which basically cause blockage of the ventricular system. Now, this clinical presentation can have an overlap as well. And there's some babies who present, who go home, come back with late onset sepsis because of community acquired infection. And really what I'd say is the tendency to do lumbar punctures in babies with early onset sepsis has its debates. Some people still believe in using CRPs. Some colleagues in some units have started using different kinds of systems, which basically help to predict the probability of infection and give that probability a score based on which we decide whether we're going to give antibiotics or not. So CRPs are not used. Is anybody using any of those systems in the UK?
Is it a Kaiser system?
Yeah, it is. It's the Kaiser Permanente system. And really what it basically does is gives you a probability of early onset sepsis based on risk factors and the history obtained from the mother. That results in empirical treatment, but really CRPs are not done as part of that. In the part of the world that I practice, we're still doing CRPs. And if a CRP is elevated, the NICE guidance kind of talks about doing a lumbar puncture when the CRP is more than 10, which I would say is quite an invasive test to do an early onset sepsis, because really the incidence being 0.5 per thousand live births, babies having meningitis with early onset sepsis means you'll have to do 200 lumbar punctures to pick up one baby. That's quite a few babies to subject to a lumbar puncture, but then you don't want to miss that one case. So a lot of it depends on how practice is in your part of the world. In late onset sepsis, the incidence is much higher. The incidence of meningitis can be as high as 15% based on or depending on the organism that's causing the infection. And certain organisms, in particular Listeria, Citrobacter, E. coli, and Klebsiella, do have a very high, I would say, predilection for affecting the brain. So the incidence is much higher. So in late onset sepsis, again, a lot of my colleagues would do a lumbar puncture, and then you'd really do a lumbar puncture when your blood culture is positive. But that clinical presentation may prompt you to do a cranial ultrasound. And the benefit of doing a cranial ultrasound in this setting is that it is available bedside, can be done without transporting the baby, and with minimal radiation exposure. So it's really a very non-invasive test to do, but with a much lower sensitivity for its ability to be able to diagnose pathology for infection in particular. Now, when we talk about the pathophysiology of sepsis, of kind of intracranial infections secondary to sepsis, mostly microbiological agents enter babies through the respiratory tract, the GI tract, but then eventually from either of these places have hematogenous spread. They will obviously spread to the choroid plexus, spread to the brain parenchyma, and spread to the meninges. And this is the guideline that I want you to follow. So I will be uploading a video today which talks about interpretation. So we've done a stepwise approach to the protocol. I've shared that video with you of performing ultrasound. But really, there is a 10-step approach to interpretation, which basically talks about going from outside in. And if you keep that approach of basically 10 steps, one of having a global overview of all your scans to kind of pick out big chunky things that you can see on the scan, what stands out, that's called the helicopter view, followed by 10 steps, which basically go from outside in, which basically talk about looking at the meninges, the extra cerebral spaces, then really looking at the midline spaces, looking at the paraventricular areas and the tissue in between, and then really looking at the ventricles and what is inside them, whether they're related dimensions, whether they're remnants. And by taking that kind of an approach, really, it's very unlikely that you're going to miss anything. But you can apply the same approach to infection in that really when we're looking for infection, it could spread to the meninges. So we need to keep a close eye because meningitis is inflammation of the meninges. But along with that, with the meninges, we've got the parenchyma underneath. And when you say meningeal involvement, really what we're talking about is we're talking about infection of the pia, dura, and arachnoid matter. And really, alongside that meningeal inflammation, you'll have infection spreading and causing arthritis and phlebitis. Or you can have the small blood vessels of the superficial areas of the brain involved. So just to annotate, I'm going to draw out. You can see that when you develop infection of the meninges, they become thick, they develop exudate on them. But along with that exudate affects the blood vessels that supplies the superficial areas of the brain, perforating vessels which supply the superficial areas of the brain. And this can really lead to what we call as segmental strokes in the superficial area of the brain, small areas that you might see that might initially appear quite hypodense, but on MRI, but later kind of become hyperechoic, depending on whether you're doing T1 or T2 weighted imaging. But really, in the brain, the way they would present is with kind of segmental arthritis. And picking that up on an ultrasound can be quite difficult if you're just using a curvilinear probe. Really, what you have to be able to do, I think, if you have a high index of suspicion, is do your curvilinear images first. And then, as Anna was showing us, really think about using the linear probe. And the linear probe has to be used not just to look at the meninges, but to look at the blood vessels that are associated with it. In general, once you've done and looked at the meninges, what you've got to look is at the parenchyma. And really, with the parenchyma, we know that there are blood vessels that are supplying deeper into the parenchyma. So not only is there a risk that you can have infection of the brain parenchyma that can present with liquefactive necrosis, but you can have walling off of that necrotic area with accumulation of pus and size, which causes abscess formation. And really, that gives you a very typical appearance on ultrasound, especially if it's associated with certain organisms. But eventually, the blood supply of these areas, because of arthritis, secondary to exudate, secondary to inflammation, compromising the blood supply, can result in strokes. And really, a stroke can be focal, involved a particular area of the brain, very similar to depending on which artery is involved. But at the same time, you can get venous inflammation, and venous inflammation would basically affect outflow, which would cause edema, back pressure, and that can present with parenchymal venous hemorrhagic infarction. So you can get features then in the parenchyma of both stroke-like kind of appearances, or you can get hyperechoic areas that basically represent necrosis with exudate. Or you can get abscess formation, which tends to be hypoechoic in the middle with margins that look bright. And then the third system that you see in the kind of brain is the collecting system, which is the ventricles, which collects CSF. And really, if you start seeing infection there, then you start seeing a brightness to the ventricular walls, but exudate in them, or even affection of the choroid plexus. We call it plexitis. So plexitis. So really, it's inflammation there, and inflammation there can cause bleeding. So you can even get intraventricular hemorrhage. So in summary, infection can give you virtually any presentation in a baby, but what we know is that certain organisms give certain typical patterns. That being said, the only way to make a definitive diagnosis of meningitis in particular is really doing a lumbar puncture, looking at the results of the CSF, and then seeing what you culture. The challenge from our perspective is often babies are quite unstable during this period, and we tend to defer the lumbar puncture. Now, if you defer a lumbar puncture for even 48 hours, there is a risk then, from your perspective, that you might not grow the organism. You might still get a high cell count, a low sugar, and a high protein, all of which take a long time to actually normalize. Weeks. In babies who don't respond to antibiotics, it can actually be much longer, even months. Uh, I think the challenge from our perspective then is how you differentiate this from pathology that already exists, especially in preterm babies who might have had an IVH or who might have existing white matter injury who've developed late onset infection and are now presenting with an infective pathology. And that really is index of suspicion and clinical correlation. So if you've had a previous IVH in a preterm baby, that's a grade 4, and that baby develops late onset sepsis, then serial scans and knowing how your scan has changed in the context of that infectious episode, clinical correlation is the key to trying to make your diagnosis of meningitis alongside with laboratory parameters of infection markers and doing a CSF. So it's not definitive. I would say that for most neonates in the neonatal unit who are acutely unwell, especially if they have meningitis, unless you have an MRI on the unit, you're really not going to send them for an MRI. You're going to treat empirically with antibiotics, do your investigations, and cranial ultrasound becomes one of the bedside tools to kind of help you. I've spoken about the 10-step approach to interpretation. I will share the video of that today. It's literally just 10 minutes. It's really easy to watch. There's a whole chapter on it. But what I usually say is move from outside to in. And really, from your perspective, that really makes the diagnosis of an infective process a little bit more, I would say, structured. In that we know that meningitis or an infection that presents with neurological manifestations of the brain being affected as part of that infection starts because of hematogenous seeding of the meninges through blood vessels. And that really produces inflammation. Now, this meningeal inflammation basically presents with highlighting of the sulci. So they become edematous. They tend to accumulate inflammation. The blood vessels and vascular supply to the meninges increases. The content of water in that area because of edema increases. And really, we know that once you start having that, there's going to be a different acoustic impedance between ultrasound waves that penetrate the brain than if the meninges were completely normal without increased vascularity, without signs of inflammation. And that will make them appear hypoechoic. You will see sulcal widening, and you can see what we describe in MRI as cortical highlighting. In the acute phase, you can see sometimes collections develop after a few days with widening of the extraaxial spaces. But really, if you don't show response to antibiotics, then those collections often will increase in size, and you can see subdural collections with exudate if you use your linear probe. Often when you use your normal curvilinear probe that is just visible to you as increased extraaxial space. And from our perspective, often when we look at preterm babies who have late onset sepsis, we attribute that to previous brain injury. But if a baby's seizing and he's got a positive CSF, just remember he might actually have a collection in that extraaxial space, which is making the extraaxial space wider. So again, it's one of the important things to keep in mind. When you go to the cortex, as I described to you, the abnormalities in the parenchyma cause significant inflammation, vasculitis, and they can present either with hemorrhagic or ischemic infarction. So really, if you've kind of got a situation where you've blocked a blood vessel off because of arthritis and inflammation, you're going to get ischemic infarction. But really, once you give antibiotics, and in particular for babies got DIC, low platelets, his clotting is deranged because of coagulopathy, then that ischemic infarct can actually hemorrhage. And reperfusion of that area may actually cause the blood vessels to bleed. If you have venous infarction, again, back pressure changes can cause hemorrhage as well. But really, what you're going to find is an evolution where you see focal echogenicity, a wedge-shaped infarct in the setting of having meninges that look quite enhanced. And we're going to look at a few cases today. You can then see abscesses, but what is a common presentation where you have not done a lumbar puncture and a baby's got fulminant sepsis and is starting to fit? What are the common things that you might see on ultrasound other than these? Anybody? So it might just be cerebral edema. You might have a baby who's basically got raised intracranial pressure because of infection in the brain. And often what you find is when you do the scan, if especially you have a preterm baby who's had sulcation, gyration developing, you find that this is suddenly the sulcation, gyration has completely disappeared. The interhemispheric fissure does not look as wide. The sylvian fissure looks, less prominent. And while I'm giving you a description, I'm going to show you the images as well. But I just want to give you a flavor of a little bit of the theory behind it, in that toxemia, inflammation causes exudates. Exudates basically in the brain, compromise blood supply, compromise venous exit, and that basically causes cerebral edema. So the only manifestation you might have of infection might just be cerebral edema. And really, again, if you've got cerebral edema in a baby who's got severe neurological kind of clinical symptomatology, is fitting, you probably don't want to rush into doing a lumbar puncture immediately. While the risk of herniation would still be low because the fontanelle is open, that's probably a very sick baby. And you, in that situation, would like to think that you've started antibiotics that cover for infection, that cross the blood-brain barrier. In the more chronic phase, what we've seen is cerebral abscesses, especially if you have poor response to antibiotics. But they can develop even if you've got good treatment, because not all antibiotics, even CSF penetrating antibiotics, are able to achieve good concentrations in certain areas of the brain. Eventually, if you've had very damaging kind of, I would say, meningoencephalitis, you can end up with atrophy, PVL-like pictures, and cyst formation. Now, with the ventricles, especially because blood supply to the inner part of the ventricle is extremely poor, the ventricles may not necessarily, from our perspective, actually be affected at all. But as I've mentioned, in the early phase, you might have slit-like ventricles, but you might eventually develop infection of the ventricles because antibiotic penetration into those areas is quite poor. And really, that is often characterized by terminology that we call ventriculitis. If the choroid plexus is involved, as I said, it's called plexitis. But it can present with intraventricular hemorrhage, intraventricular debris. You can see strands, septation, especially in the more chronic phase. And really, in those situations, when you have bleeding or you have exudate, it will block the ventricular system. And the complications that we commonly see are septation, compartmentalization, and hydrocephalus. So the reason I've taken my time to kind of give you this approach and to talk about it is because that's the structure I want you to keep for all scans. Always interpret from outside inside. Just remember, when you're in your coronal views, uh, outside to inside. When you're in your sagittal views, outside to inside. If you want to do your Dopplers, finish them with your coronal and sagittal views. So really with your sagittal view, you are going to do your ACA Dopplers. You are then going to move on to other views. Now in term neonates, the PF may be closed. It won't give you a lot of information. The mastoid fontanelle and the temporal fontanelle again will have very small windows, and it's quite challenging. So really most of your information in term neonates is going to come from the anterior fontanelle. But just remember, in preterm neonates, these extra fontanellar spaces, the posterior mastoid and temporal, can give you very good information. And they can really help you delineate in situations where the anterior fontanelle is either asymmetrical or small. So don't hesitate to kind of look at these regions as well. Now, I'm going to come to basically talking about the theory. And as part of this, what I'd like to say is that in your article library, there are a few articles that I have kept for you to read, and a very nice article that's been published that's available on the internet is an article that's basically been published by the European Ultrasound Brain Group, which basically works with the European Society of Pediatric Research. It's an absolutely amazing article, which basically gives you all the different presentations alongside the different pathologies, again, using the same structure that I've done, but also gives you organism-specific kind of manifestations that we will talk about in a lot more detail than I can actually cover as part of the session today in 45 minutes. But again, if I highlight to you uh, certain changes. So one of the things that's really prominent over here, and I want all of you to kind of focus on the meninges here, is A, they look quite bright in the coronal view, but you have a lot of extra axial space. Now, if this is the first scan that I'm doing in a term baby, really, I would really worry about why a term baby has got prominent ventricles with a lot of extraaxial space with what I would say is highlighting of these sulci and gari. They look really bright. Now, if this is a baby who's had seizures, who's lethargic, who's come to me and is about 48 to 72 hours of age, whose mother has GBS, I would be really worried about the potential that this is either early onset infection with meningitis or a late onset infection with meningitis. Depending on the baby's stability, I mean, if I'm doing a scan because this baby's had a seizure, I would be thinking very strongly the potential that there might be an infection here. And the reason for that is when you look at this entire area over here, not only do the sulci and the gari, the sulci in particular look very bright, they're very highlighted, but you've got this area that looks very fuzzy, and this is really exudate. And it makes me feel very worried. But if you want to see this a little bit more clearly, then really what you need to do is you need to change from this curvilinear probe to a linear probe. Now, the window here is curvilinear. The window over here is a straight footprint. It is still curvilinear, but this is characteristically the footprint of a linear probe with a high frequency. And can you see how well it delineates the outer layer of the meninges from what is the pial layer of the meninges and then really the arachnoid layer? And you've got this echogenicity in it with a lot of kind of extra axial space. Now, if a baby comes to me at 72 hours with seizures, with lethargy, has had no instrumentation, is in a situation where he's not had any kind of trauma that would precipitate this kind of a clinical appearance, and there's no drop in hemoglobin, again, infection would be something that would really worry me because the actual highlighting of the sulci that I can see over here makes me feel quite worried. In the latter phase, let's say this baby came to me at birth and I treated with antibiotics, and really this baby's gone on to develop sequelae. Then again, in situations like that, one of the sequelae that you might see is ventricular dilatation. Again, secondary to the fact that you've had severe infection and the brain's not growing. But really, in the chronic phase, this exudate tends to organize itself. And really, from our perspective, you can develop superficial kind of areas of, uh, I would say, segmental kind of strokes in the brain. Now, can you see in this particular situation how they're not very well highlighted in the acute phase, but in the chronic phase, really what I'd be doing is taking the linear probe and trying to have a look to see whether I can see any segmental hyperechogenicity. And you can see at least one area over here that looks very suspicious, another area over here that looks very suspicious. So taking the linear probe and kind of exploring this would give me a little bit more information. So Serial follow-up of these babies with ultrasound is also possible, but experience usually says that we follow it up with kind of MRI as opposed to ultrasound. But these are acute and chronic changes that you can see in the meninges. This is just, again, a slightly closer image with the linear probe. And can you see how thick the pile layer actually looks? The arachnoid layer, there's exudate, again, a very bright kind of an appearance to it uh, that you see. Now, this, from my perspective at this particular point, again, it just worries you a little bit, but you have to clinically correlate. Here, there's absolutely no doubt. Just look how bright it looks. It's echolucent, it's bright, and you have a lot of exudative areas that you can see within the actual extra axial space, which basically gives me real worry that you've got exudates over there. And when you do the corresponding MRI, what you can see is this classical cortical highlighting. So this is classical meningitis after clinical correlation. Really, a CSF in this particular baby has given a positive organism. And if you read the article, they actually tell you what organism the baby's actually got. But again, very, very highlighted kind of sulci and gari look very bright, again, with increase in extraaxial space with actually exudate visible in them. These are both with the linear scan. So really, experience says that you're probably going to do this scan first. And really, if you have a high index of suspicion, then default to the linear scan. If you don't have the linear scan, then my advice would be to try and use the highest frequency possible and basically zoom into your image to try and keep adequate resolution. And just remember, it's based on our theory of ultrasound physics, which basically says that the higher frequency gives you better resolution because you'll have less depth penetration, which means the ultrasound waves will interact with tissue better. So you can use your curvilinear probe, use a slightly higher frequency and zoom into that particular area to have a look, and you'll be able to get images. Nora has basically asked a question. Okay, so I will open up to any questions so far. Any questions? So interestingly, from my perspective, when you want to look for meningeal enhancement, it can be very subtle. And this is a classical case where if you look at the ultrasound, really the enhancement that you see over here, it's quite subtle. It makes you very worried that you can see this kind of area over here that looks quite echo bright. Again, an area over here that looks quite echo bright. But with artifact in your machines, especially with some machines, they tend to give artifact that causes echogenicity that may be visible. And really, it's really important that your gain settings are set appropriately, because if your gain settings are set very high, you will tend to exaggerate the kind of appearance, which may then make you feel worried that this baby's got meningitis or a meningoencephalitis. Now, if you're doing a scan, let's say for a term baby who had hypoglycemia, because you want to kind of look at the brain and the occipital areas. Very rarely you'll pick up any changes. It's more MRI that picks up those changes. But let's say you did it and you picked up enhancement like this because of high gain settings, and your baby's completely well, has got no signs. That's what clinical correlation is all about. It's really important that you don't overinterpret. But the real important thing is, even with subtle features like this in babies who've got meningeal enhancement, parenchymal kind of echogenicities that you can see over here, an MRI will give you a lot more information. At the end of the day, we have to analyze the parenchyma. And like I said, kind of presentations with stroke-like syndrome, so bright echogenic areas, and this is classically the middle cerebral artery area that's kind of involved, temporal lobe over here involved as well. And that's because of arteritis along with infection. Again, really what you can see here is the whole of the brain parenchyma has kind of been destroyed. There's liquefactive necrosis that's happened, which has destroyed this. And this happens more in the chronic phases. So in the acute phase, you might get parenchymal echogenicity. But later on, very similar to the way you develop PVL, you develop liquefactive necrosis, which gives you these large necrotic areas. And this is usually seen with chronic change. So this is the early kind of clinical presentation. And then really this is a follow-up scan that's done later on. And this really is a very severe infection. So it might just be a presentation that affects an arterial territory that then progresses to a kind of a PVL-like necrotic appearance, or you might just have IVH. And a very classical example of IVH is, babies who have DIC, coagulopathy, or potentially a baby who's become dehydrated because he's lethargic because of infection. He's developed sinus venous thrombosis. So again, you've got bilateral IVH over here. You've got echogenicity, again, in the basal ganglia region over here, thalamus as well. But really, if I see this kind of presentation, I would still be taking my linear probe and having a look, because superior sagittal thrombosis, superior sagittal sinus thrombosis may be part of this infected process. So again, I'm just highlighting to you that there is no set pattern in which infection actually presents, but we have certain organisms that have predilection to certain areas of the brain. And really, in some situations, sometimes what you'll then see is an initial area of echogenicity where maybe you haven't got good antibiotic penetration, which undergoes liquefactive necrosis. And really, you've got hyperechoic areas with this kind of ring of echogenicity with a hypoechoic area. And this is really what we call an abscess that's in process. It can have different levels of echogenicity depending on what it contains inside it. But if it's got fluid and pus, we know the acoustic impedance at the margins will be high. So the margins will kind of highlight. But because the density of fluid is relatively constant, you will have a kind of a hypoechoic appearance in it. If you have debris, if you've got protein, if you've got high protein in it, you might find that's a little bit more echogenic than normal. So these are different kinds of abscesses that you can see in this particular situation. But these are usually seen in the chronic phase once you've started antibiotic treatment and if there's a poor response. But really, once infection spreads to the ventricles, we're in big trouble. Because if you have ventricle related infection or ventriculitis, antibiotic penetration into these areas is really poor. And these are kind of babies where you tend to develop what I would say is post-hemorrhagic hydrocephalus because of the exudates causing blockage of the ventricular system. But really with antibiotics, say treating these areas, and this is really echogenic clot. So this baby's had an IVH secondary to an infection, and in this process has got ventricular dilatation. And really, from our perspective, when you look at the mastoid view in the cerebral hemispheres, you can actually see a small abscess there. So it's really important. You might end up missing infection in a particular area of the brain if you just restrict yourself to the anterior fontanelle. So being able to do those additional fontanelles is really important, even for babies who have infection. And I would say that what we must get into the habit of is, as we described, there are three kinds of scans that we do. There's an enhanced scan, there is a comprehensive scan, and then there's a point of care scan. And really, in these kind of babies, I think what you're talking about is doing a comprehensive scan. In a term baby, the PF is almost always very small. Getting good high quality images is not really ideal. The temporal and the mastoid windows can be quite small, but as Anna has really nicely demonstrated today, getting a mastoid view is not difficult. It's just about getting your window, getting somebody to put the baby into the right lateral position. And really, I would be looking at the left side and the right side if I was worried about infection. I think if I was just doing measurements, I think doing one side, if you got a good view of the cerebellum, it would be really helpful. But again, just an abscess in the mastoid view. And then the cerebellar hemisphere over here, again, you can see this area, which basically looks quite echogenic and really has lost its anatomy. So again, just evolution of an abscess. Now, with the ventricular system with treatment, often what you'll find is you will find that with treatment, the ventricles often have exudate in them, and this exudate gradually resolves. So you might find that ventricular dilatation becomes better with time. But ventricular systems may appear septate because of these exudates, because of fibrin strands. And this is what makes the penetration of antibiotics quite difficult. But eventually, in some babies, despite 3 weeks of treatment, say if you have a gram-negative infection, you might have ongoing ventriculitis because the antibiotics can cure the parenchyma. They can get into the meningeal areas because blood supply is reasonable to the parenchyma. It's really good to the meninges, but getting into the ventricular system is really poor. And that's what leaves you with sequelae, which sometimes means that you cure the meningoencephalitis, the meningitis, the parenchymal infection, But because of these sequelae, these fibrin strands, the proteinaceous material within the ventricles, these babies go on to develop post-ventricular dilatation after infection, and some of them will go on to need shunts. So that's in summary about the different presentations. And what I've kind of given you is a little bit of an overview of the different appearances. You can get virtually any appearance. So it is really crucial that you clinically correlate. Any questions about that? Because we're going to go into a few cases now. So for the cases, as you know, I like to pick on people, pair you up. So who have I got? Uh, we've got somebody new who's joined us. Maria, can you hear me?
Yes.
Lovely. So Maria, I'm going to give you a history and then I'm going to show you some images. And you're going to help me interpret those images. And you have Dr. Hassoun with you. He's your buddy. Dr. Hassoun, can you hear me?
Yes, I'm with you.
So both of you will unmute, and I'm just giving you a history. So this is the first case, which is an ex-26 weeker who is kind of about 36 weeks corrected age. The baby's had complications of NEC, and at about 10 weeks has developed symptoms of lethargy and fever. So the challenge from our perspective is this baby's had quite extensive bowel resection, and we've been trying to feed this baby, and this baby developed some loose stools. After the stools became loose, the baby became quite lethargic, then was not kind of stopped feeding. He was having alternate tube and bottle feeds, but really has completely stopped feeding. And he was screened and started on antibiotics at this point. At 24 hours, our CRP was about 60. At 48 hours, it went to 200 plus. And then we grew Klebsiella in the blood culture. And this baby was on antibiotics. He also developed problems with a very high shrill cry. And I think along with the high shrill cry, there were concerns that he might have had subtle seizures as well. So not the classic clonic tonic kind of seizures, but more kind of a wide vacant stare. I would say with really an exaggerated startle and a high shrill cry, making you worry that these might actually be seizures. So the baby's 10 weeks old, and this is a scan at about 72 hours. Any questions you'd like to ask me?
Already on antibiotics, Alok, yes.
Already on antibiotics. So, yep, good antibiotics that'll give good gram-negative cover. And the antibiotics have been rationalized to sensitivities by 72 hours. So, but the CRP is still in the rising phase, 200 plus.
Yeah.
We don't have any electrolyte disturbances also.
Not at the moment, no. The baby's not needed intubation ventilation. He's hemodynamically stable. We had to stop feeds for about 48 hours, but then we restarted trophic feeds on day 3. He did have phenobarbital for the seizures, but they didn't cause any respiratory depression. And at the moment, he's predominantly kind of on IV fluids with some nasogastric feeds at about 30% of the total on day 3. No hemodynamic instability, normal lactates, gases are fine.
Not on antifungal prophylaxis also.
No, not clinically at the moment, no.
And what about the blood culture with the septic workup?
So the white cell count was 22. Platelets at the moment are about 150. The CRP went up from 67 to 220.
No, the blood culture?
It's grown Klebsiella.
Okay. And so at that point, so I don't know, maybe I'm anticipating. And at that point with the positive Klebsiella, or even before it received the lumbar puncture as well?
Good point. So yes, a lumbar puncture was done, but it was traumatic, unfortunately. It was frankly traumatic. The baby is quite difficult to kind of flex. So unfortunately, lumbar punctures were attempted on 2 occasions and came back traumatic. Any other questions? So it's difficult. We think he might have clinical meningitis, but we've had a traumatic lumbar puncture. We are treating seizures. So what can help us?
Sorry. So what about, well, just from a treatment point of view, what antibiotics is he on?
He's on good antibiotics.
What?
he's on good antibiotics in the sense they cover for Klebsiella.
Okay.
So in my part of the world, we'd use meropenem
Okay.
very early on. I think for this kind of baby, with our kind of second line for treatment in babies like this is something that crosses the CSF. And the problem is tazocin will not cross inflamed meninges. Cefotaxime will cross inflamed meninges. But so this is a case that I'm presenting from the UK. And over there, what I would say is that in situations like this, we would probably have started cefotaxime if it was fully sensitive. But in the UAE, we have a very high incidence of ESBLs and of resistance whilst we're doing treatment. So often, if we want to cover for meningitis without uh, a positive CSF and sensitivities, we would probably escalate to meropenem quite early, which
Okay.
yeah is not quite antibiotic stewardship. What would you guys use?
Yeah, I think once we get back the bag, we basically base it on the antibiogram.
Yep.
Before the second line, here are mostly gram positive. There are less gram negative. In Milan, where I used to work before with lots of surgical cases, yeah, Klebsiella was one of the problems, and we would start meropenem as a second line though. First, an aminoglycoside and
Yep. Is another option. Yep. So our second line here is Ticanamica. But again, the worry about using the aminoglycoside on its own is if you're worried about meningitis is the CSF penetration.
yeah, no, and plus if there was a meningitis plus cefotaxime.
Yeah, fair. So we did an ultrasound. He didn't have central access at this point. So what do we think? So this is basically C1, C2, coming back to C3, and then you have two images of C1.
I'm not, so maybe the extraction space is a bit enlarged, but this is an preterm. I don't know. Sometimes I see them like that, even if there is nothing going on.
Fair point. So if I were to say to you that previous scans did not show such a widened interhemispheric fissure.
The previous one from this patient.
Yep.
Yeah. Yeah. So that one isn't, yeah. So if the previous one was less, so for sure this is enlarged somehow.
Anything else?
The third ventricle is a bit prominent.
Yep. It is a bit prominent for a 36-weeker, I'd say. Ventricles look reasonable for next preterm. So, I mean, baby with a good kind of head circumference, good growth. So the extra axial space you would expect not to be wide. Okay. Dr. Hassoun, you happy with that?
Yes, the sulci are more prominent يعني for 28 weeks.
So he's 36 weeks corrected.
And just I'm wondering the Sylvian one on the right side could be a little bit bright or in comparison to the to the left side.
Okay. Okay. Fair. No problems. So one of the things that I want to point out is that time gain compensation is really important over here. In that if you look at and you cut the image into two halves, let me use my pen. Basically, sorry about this. This part of the image looks brighter than the lower part of the image. This part of the image looks brighter than the lower part of the image. So really what I need to do to image optimize here is I need to increase my time gain compensation in this area just to basically make it equally ecogenic. But the second question that I would pose to both of you is why, when I do that, If I find no difference, is that clinically important?
If you find no difference changing the gain.
So, yep.
So,
So what I'd say is it could be a marker that there is meningeal enhancement and highlighting of the sulci and gari. But here you don't see many sulci or gari. So hence, it may be that really the upper part of your image is abnormal and your gain settings are okay. Now, that is something that you will realize once you see the next image. So have a look at this image. Now, what do you think? So I have improved my time gain compensation in this image. So what do you think, Maria?
yes, so in the upper part, the meningeal borders are quite brighter, and yeah, as you pointed out, there are not that many below,
Yep.
so it hasn't changed much from the previous one, probably because the meninges are quite bright. I would be worried though to interpret this finding
On its own, but
on
we
its
have to look
own.
at it in two planes, right? So we're going to look at it in two planes.
Okay, yeah.
So we're only looking at it in one plane. I completely agree with you. It's very subtle, but just remember clinical correlation, high shrill cry, seizures, CRP of 220 in this baby.
Yeah.
So, but we need to demonstrate in two planes. Anything else? Anybody else?
So
Any?
the
Yeah.
only explanation, Alok, it could be cerebral edema because we have some difference between the two compartments.
Yep, that's a good point. My only comment about cerebral edema is your ventricles are decent size. They're not very slit-like. And actually, you can see sulci over here as you move backwards. But yeah, something to consider. It could be cerebral edema as well. I can see a decent sylvian fissure, but maybe that area, yeah. But let's see. Occipitally, again, not much to say, just a little bit of meningeal enhancement. So now what do we think?
Yeah, it's announced for sure, yeah.
Yep. So really what you can see when you look at your interhemispheric fissure, and I don't know why I can't rub out this, erase all the ink on the slide. Yeah, thank you. So again, can you see how this is a very focal kind of an involvement of the interhemispheric fissure in the midline? And really when you go into the midline view, now can you see the meningeal enhancement?
Yes.
It's obvious.
Yeah. And what I'd say is really echogenic area in the midline. I mean, here you're really worried. Are these going to evolve into something more sinister? Can you see those small areas? And really, what you need to do is basically take a linear probe and interrogate this area very, very well.
This
And
hyperechogenicity, Alok, this is what just it could be hemorrhagic or
it could be
ischemic.
meningitis. No, it could be meningitis with exudate, simple exudate. But really, when I start looking at this area over here, it's not wedge shaped, but it is in the anterior cerebral artery territory. So again, it could be vasculitis, it could be exudate. It'll be difficult from our perspective to kind of say this on cranial ultrasound. And that's why I would say to you, try not to overinterpret. Describe what you can see. My challenge at this particular point, obviously, was we didn't have a linear probe where I was working. So I couldn't use a linear probe. But when you look at the right side, and this is important because we're going to compare it with the left, what do you think about the sulci here?
Compared to the left.
So okay, let's show you the left. So this is the left.
Yeah.
So less bright.
Yeah.
When you
The
look at
right,
the left,
the
the right
left is
is,
brighter.
yeah,
Right.
absolutely.
Yeah.
Left is brighter. Okay. And when you go back to your coronal views, it's very difficult, but actually with the eye of faith, if you look at this margin over here, it's definitely brighter, though the right is brighter there. But I would be quite worried that actually the midline and the left side are more echogenic as compared to the right side.
Yeah.
So unfortunately, where we work in the UK, you kind of have a maximum of 3 attempts at lumbar puncture, and we tried and failed. So we treated this baby as clinical meningitis. And this baby basically had 3 weeks of antibiotics and made a good recovery clinically. No focal neurological deficits at the end of it. Uh, Unfortunately, I was not able to repeat an ultrasound. Baby went on to have an MRI, which showed a lot of cortical segmental and microinfarction. And I unfortunately haven't got the MRI images, but can you just see how subtle it can be at the start? I mean, if you're looking at this image for the first time in an ex-preterm baby and he's had no previous scans, I mean, this could just be a normal preterm scan.
Yeah, exactly. I would be worried about that, that it could be almost normal.
But as you move forwards, you're now demonstrating it in more than one plane. So clinically, from our perspective, we then demonstrate on MRI as well those changes. So again, it's clinical correlation. I mean, it took a good 2 weeks for our CRP to come down to kind of under 50. And we had this baby pretty much defaulted to cefotaxime, a step down from meropenem once sensitivities were available. The baby ended up with 3 weeks. So, any questions? Well done, guys. Well recognized. If you feel confused in situations like this, then really what you need to do is speak to your friendly radiologist as well and ask him what further neuroimaging will help you make further diagnosis. So, have you all read the God's Principles? Has anybody read about God's Principles? No, you haven't, because nobody's read the text. So I'm sending you the presentation today. What I would say is really important to have just watch the summarized videos of the first 7 chapters. And you will, if you've actually done chapter 3, then you will see what God's principles are. And basically, what they say is that cranial ultrasound findings really lack sensitivity and specificity with infection. So you just have to be extremely careful. You need to clinically correlate because in a completely normal baby, uh, the two questions that I would really ask myself is, what is my time gain compensation and am I using it properly? Is that what explains the difference in the sulcal highlighting? But in a baby like this, clinically, I'd be very worried about the possibility of meningitis. Even affection of the parenchyma. If you see the kind of area over here, it's very echogenic. This is normal blush on the right side that you see over here. On the left side, actually, other than this kind of sulcus, everything else looks very much normal. But on the right side, especially towards the midline, this is kind of what I would call is what would fit with a focal cerebritis. And if this did not respond to antibiotics and we had a nasty bug, then really this is an area that I'd be really worried about. This can evolve into a focal cerebritis and can go and form an abscess, as we'll see. Not in this baby, but in another one. Okay. Who wants to do case 2? Any volunteers? Okay. Shinza, can you hear me?
Yes, doctor, I can hear you.
Lovely. And we've got Dr. Devedi. Dr. Devedi, can you hear me?
Yes, sir.
Okay,
Yes,
so
sir.
I'm giving you another case. So term baby has got maternal sepsis uh, in the early part of the pregnancy. So basically, first and second trimester, this mother basically was treated for quite severe infection. She had UTIs, persistent E. coli UTI in her pregnancy, and then ruptured her membranes about 28 weeks. So she's had multiple courses of antibiotics. And again, just before delivery, she had an HVS done, which grew E. coli. She was treated adequately with antibiotics as per our protocol. And really, from our perspective, when the baby was born, he was born really, I would say, with no respiratory effort, needed IPPV, was intubated, ventilated pretty much from birth, presented to the neonatal unit completely shut down, needed volume, was escalated onto multiple inotropes over 48 hours. The initial CRP on the first set of bloods was 60. White cell count was about 50, very high neutrophilia. And over a 48-hour period, again, we had another kind of a rise in CRP to 200 plus. This is a baby where we had a successful lumbar puncture done. I would say pretty much after birth because the CRP was 61. At that time, the baby wasn't on inotropes. And basically, the white cell count was 200 with a sugar of 0.3 and a protein of 1.8 gram per DL. So the baby is currently 48 hours of age. He's tubed. He's on multiple inotropes. His gases basically, after the volume correction, the inotropes show initial lactate of 9 that's come down to about 3.5. He's otherwise kind of stable gases. CO2 clearance is not an issue. Base excess is normalized. So any questions?
Was he started on antibiotics?
Right at the start. So based on clinical presentation, he started first line benzyl penicillin, gentamicin, but with the CRP having gone up, they've been broadened to cover, especially after the E. coli came back. So he went on to cefotaxime after that CSF.
And the cultures?
So cultures grew E. coli, fully sensitive to the cefotaxime. So he continued with Kef and Gent because his renal function was okay. And the cephalosporin cefotaxime was added in for CSF penetration. Should we have a look at the scan?
Yes.
So this is the first scan at 48 hours of age. So is this coronal or sagittal?
Coronal.
Okay. So tell me, talk to me. So you can see the coronal C1. And then really what I'm trying to get here is a C2. And then I'm trying to get a C3. Oh, by the way, he's also had seizures and phenobarb. Very bad
Is a
seizures.
hyperintensive?
Okay, so what protocol are we going to use? We're using the 10-step method. So we're going from outside in, and we're going from front to back in coronal views. So let's talk about the frontal image first, C1. Out to in.
So the meninges are looking hyperechoic. There's
Okay, so they're bright. Certainly over here, they look bright. Yeah, okay.
Gyral size are it fails.
Very good. So there's no sulcal gyral differentiation here. There's no sulcal. I mean, for all practical purposes, when you look at the front, you can hardly see any sulcal. This is a term baby. Okay. What else?
on the left side there's a hyperintensity on the left side.
Yeah. So there's a hyperintensity on the left side. So we talked about meninges. We talked about sulcal gyral differentiation pattern. What about the frontal horns? I should normally see frontal horns over here. Am I seeing frontal horns?
No.
No.
Okay, so I'm not seeing a frontal horn on the right side. I've got sulcal gyral effacement. I can barely see sylvian fissures in the midline. Again, hardly any sulci. So what am I thinking?
There's no interhemispheric fissure either.
Yep, very good. So what are we thinking?
Maybe cerebral edema.
Okay, so we see cerebral edema. Now, is this the frontal horn?
Not sure.
It's very irregular for a frontal horn.
Hmm.
And if
Yeah.
it was cerebral edema, it would be effaced. But I've got a
Yeah.
very echogenic lesion very early on in this baby on the left side.
Yeah.
What about the midline?
Can't see the midline.
Very difficult to see the midline, but can you see this midline? It's pushed.
Yeah.
Yes.
So this
Yes. Yes.
echogenic lesion is actually causing midline shift
Mm.
and
Okay.
general echogenicity. It's generally echogenic. And I mean, I just really worry. This already looks necrotic. It's
Yeah.
really worrying. So, I mean, I'm just looking at this picture, and what I've got is a very hyperintense region, ipsilateral to the ventricle in the parenchyma or in the ventricle. What do we think?
Hemorrhage?
Parenchyma.
Yep, the ventricles are basically effaced. You have midline shift. So this ventricle is probably completely collapsed. This is parenchymal hemorrhage. Or,
Hemorrhage.
or, so I don't,
Abs-
wrong word. It's parenchymal hyperechogenicity. It's very echoic. Whether it's hemorrhage or not, we can't be certain. This baby had a normal hemoglobin at this point, but it moves from the frontal region where it's less echoic. Okay. So, I mean, it's really worrying at this particular stage, especially if this kid has meningitis. Now, what do we see?
Quite difficult to
Okay.
see anything, any of the structures.
Yeah.
So you're absolutely right. Basically, normal anatomy is completely effaced. I mean, even in the midline views, I can barely see a Sylvian fissure. There's just very gross cerebral edema, no sulci, and this large echogenic lesion on the left side. Maybe with the eye of faith, I can see a lateral ventricle here and some of the midline on the right side, but the left side, there's this large echogenic lesion. Now, it could be a parenchymal infarct, could be hemorrhagic, either of the two. We can't be sure. But what you can see is that it's less echoic here and very echoic here. So it could be a mix of both, maybe a parenchymal infarct where there has been hemorrhage. The question from my perspective is really when I look at this, there are two very obvious things. There's cerebral edema and there is a focal hemorrhagic infarct in a baby who's got positive CSF. I mean, this, from my perspective, really fits with a parenchymal kind of an injury that's quite severe. And I've got necrosis as well. So for a baby at 2 days having this kind of pattern, when do you think the insult has happened?
Neutral.
Antenatal.
Yeah, it's happened in
Antenatal.
utero. Yeah, MRI will
Mm.
give us much more information. So this is just, can you see the image moving?
Mhm.
Can you see that?
Yeah.
Yes.
So again, ventricles just about visible, but really hyper intense area over there. Brightness even on the right side in these areas. And then I basically go to my, so with the eye of faith, that is the occipital region. So these are the midline.
Hello, sorry, can I ask you something? Could it
Please,
be the beginning of a brain abscess as well, or it's not
we can't
compatible?
say that now. We have to do CL scans. I'll come to that with the next case.
Okay, but it could be what I'm
It
saying,
could
like
be, yeah, could be,
like that. Okay.
yeah, could be. We'd need to do CL scans. And, and if this baby was stable enough, we would have had an MRI. But yeah, but I mean, again, you're right. If it undergoes liquefactive necrosis with antibiotics, that's an area that basically could evolve into an abscess. Just coming back to the sagittal kind of images, you remember the left was really bad. So if you look at the left over here,
Mm.
what do we think, Shinza?
Um,
That's very
there
good.
are hyperintensities
Yep.
almost in most part of the parenchyma.
Yep.
But I can't see the ventricles.
Okay. So basically, uh, this is not ventricle. This is necrosis.
Oh.
This is basically
Oh.
necrotic. It's brain necrosis, like you see in PVL. So you see these hypoechoic lesions over here. massive
Yes.
hypoechoic regions, so this is basically left side complete, and this is the kind of cortical hemisphere. So this is the temporal lobe, this is the parietal lobe, and basically you've got a massive echogenicity there with breakdown. So I mean, this baby's been antenatally affected. And on the right side, the same image. Again, can you see these cystic lesions?
Yes.
Yes.
Again, so just the right side, you see a lot of hyperechogenic areas. You're getting kind of the Sylvian fissure, but really there's no anatomy defined. So, I mean, this is very severe to the point where actually the meninges have dropped back. This is an area of necrosis that you see over here. This is not an easy scan, so I'm basically going through with it. This is the midline. Can you see the corpus callosum?
Yes. No.
No.
It's completely destroyed.
No.
And you
Yes.
see all this exudate?
Yeah.
Yes. Yes.
I mean, it's a horrible
So
scan.
the dark spots are the necrotic areas.
Yeah. Liquefactive necrosis has happened. It's basically cortical hemispheres breaking down. And this is just magnified. So I've taken a magnified image of the left. Now, this is a scan of the same baby. These upper images are after 2 weeks of antibiotics. Lower images after 2 weeks of antibiotics. What do we think is happening?
Sorry.
So these scans that I'm showing you now are after 2 weeks of antibiotics.
The lower one?
All of them, all four.
Or can see a lot of cystic thing.
So first of all,
Yeah.
which image is this?
Left sagittal.
Very good. Left sagittal. It's really tangential. Temporal lobe coming into view over here.
Yeah.
This is the cortex, what's left of it. What is this?
Cyst.
Cystic encephalomalacia.
Very good. It's basically encephalomalacia. The brain is completely destroyed. Now, if you remember the right side, you remember the right side?
Yeah.
What's happened over here? This is the temporal lobe on the right side. This is the Sylvian fissure. Frontal lobe would be here. I'm using a linear probe. What's happened on the right side here?
Hypoechoic,
Very good.
like a cystic lesion.
Yeah. So it's basically encephalomalacia. There's no brain. It's a cystic area. And you have an element of infarction. So I don't quite have a walled-off lesion, as Maria was rightly mentioning, but what I've got is basically brain that's undergone complete necrosis, kind of complete cystic encephalomalacia. So, prognostically not great. And this basically is which view? Anybody?
Coronal.
Anybody? It's a mastoid.
Yeah.
Mastoid, I
It's the
think.
mastoid
Yes.
view. So I'm just giving you an example of how severe this infection was. Very severe. So baby did not survive. But this is the left side. You have no midline. You've basically got an area of cystic degeneration. That is that area. Now, Maria, what do you think about this lesion here?
That looked like that's 2 weeks later, right? It
Yes.
really looked like an abscess that is forming itself in there, right?
Yes. Absolutely. See this? It was a cerebral abscess.
Yeah.
So just again, just an example of really how severe. So I've given you two cases that you've seen today. I've given you two areas of the spectrum. And that's what I really wanted you to kind of see. That you can have something that's very subtle, but again, you have neurology. Here we have something that's happened right from before birth, and you can see progression on a cranial ultrasound. I mean, uh, neuroimaging for this baby was horrendous. So, from our perspective, some babies with such severe infection just are not going to make it. But yeah, this is just an example of severity of infection.
Doctor, can it be also HIE?
Clinical correlation. So clinical correlation, you're right, says that technically from our perspective, this baby could have HIE. He needed resuscitation. His cord gases were normal.
Okay.
Yeah. My only question about HIE is, would you see necrotic lesions right at the start with HIE?
No, but the cerebral edema.
That, again, could be. It may be a mix of both because he's needed resuscitation. My gut feeling is because you've got necrotic lesions right at the start in the first scan, it would fit more with an infective process causing edema. And he very much felt like that, Fontanelle was quite full. So really an ongoing in utero meningitis. And for those of you who worked in some of the hospitals in India, I worked in a hospital called Indore, MGM, my mother hospital. I mean, it's taught me everything that I know today. We used to get babies with frank pus at 12 hours. So they've just delivered, they've got seizures, very similar kinds of clinical presentations. And you basically do a lumbar puncture and you get frank pus. And the mother's had no antenatal care. She's got infection. We often used to culture Klebsiella or E. coli from these babies. In this baby, we cultured Klebsiella. Last case. Yeah,
can I ask,
please. Yeah.
based on the ultrasound, like this increased echogenicity, can you differentiate between hemorrhage and pus just based on the echogenicity, or is it with clinical correlation?
Yes and no. I think, can I show you this case and then I'll show you what pus looks like in ventricles?
Yeah, thank you.
What I'd say is that on ultrasound, the answer is no, you can't. The only way that you can really determine whether the baby's got pus is by doing a CSF and demonstrating that you've actually got pus. Or by basically doing, an intraventricular tap, because even an MRI might not be able to give you that information. So the nature of exudate is always determined by actually physically sampling. Let me try and get out of my rubber because the rubber is a... Okay, so last case, preterm 26 weeks, because I need to let you go. Baby with a previous grade 2 IVH and has developed late onset sepsis with Klebsiella, has also got neonatal seizures. And this is the case that I want to kind of highlight to you that you've got mixed pathology. Now, we cultured CSF. It was negative, but the CSF was kind of with a high white cell count, pleocytosis, low sugar and a high protein. So basically, we treated this baby based on the clinical presentation, high CRP as well. And this is a cranial ultrasound after 3 weeks of antibiotics. Now, this baby basically, when he got the infection, was about, I think, 30 weeks, if I'm not mistaken. So this is the scan. Anybody? It's pretty obvious.
It's obvious dilated ventricles.
Yeah. So anything particular that you want to comment on? Babies on 3 weeks of antibiotics still has a high CRP, still continuing to have seizures, has a rising head circumference.
There is this
Fontanelle,
debris in the ventricles, and the ventricle are a little bit bright, the wall.
very good. So what you can see here is brightness of the wall of the ventricle. This is classical ventriculitis. You also have some debris, not a lot in it. There's not much septation, but really what I'm really worried about is ventriculitis. Very obvious ventriculitis in this baby. The margins, can you see how thick they look? And then this area here, focal ventriculitis. And then when you look at the brightness at the occipital part of the brain, very bright ventricles again. but it's really obvious when you look at the lateral sections. Can you see how bright the margins look? They're actually as bright as choroid. That's what you're really looking at, especially in this region over here. So basically, this baby has developed post-hemorrhagic ventricular dilatation, not post-infectious ventricular dilatation. So after the initial IVH, which was just grade 2, the baby didn't have ventricular dilatation, but after 3 weeks of antibiotics, we developed it. So, and again, can you see the exudate here, the irregularity? This is not clot, this is exudate. Very irregular. You can see septation in the ventricles. Very bright corpus. This is the corpus callosum remnant, but very bright septation here, very bright inner lining. That's remnant of the corpus callosum that you see at the top there. Again, very bright lining. This is the left side. And can you see exudate? So this doesn't fit with clot. And really, once you start seeing septation like this, which is new, this is post-infectious. So we had to continue antibiotics. I mean, if you look at the midline, just look how bright it looks. The third ventricle is also dilated, and the fourth ventricle is nearly collapsed. So you really worry that exudate has probably blocked the ventricular system, which is causing the third ventricle to dilate, which is causing back pressure into the midline, which is causing the lateral ventricles to dilate. And this is classical ventriculitis for you. Just in the interest of kind of time, fungal meningitis presents classically with multiple focal areas of echogenicity that basically go all over the hemisphere. I mean, if you get this kind of a clinical appearance, the two things that you must think of are the possibility that you've got candida. But the other thing, obviously, is if you grow a gram-negative bug and you have this kind of appearance, then think about the potential that this baby's got some elements of immunosuppression that might be causing this. The evolution of a brain abscess. So as Maria rightly mentioned, often what you find is it may evolve and look like a kind of hemorrhagic infarct. This is actually focal cerebritis. And as it evolves, same baby, just in the region further back, it basically forms an area which has basically got echogenic margins with a hypoechoic area in between. This is classically a cerebral abscess. So it might be reflective of early cerebral cerebritis, as you saw in the second case that I showed you. On the other hand, some bugs like Citrobacter, Bacillus cereus, they are classically known bugs which basically cause cerebral abscess. This is a massive cerebral abscess causing ventricular effacement. I mean, we're talking, virtually the whole of the parietal lobe here of this baby's brain being affected. And then really you have use of ultrasound. Now, this is a very nice kind of a case that's highlighted in this article, which is part of your article library, where you basically have very severe ventriculitis. Again, bright ventricles that you can see over here. You can see dilatation of the ventricles. This is the occipital lobe. This is naturally the kind of sagittal section that you see over here. This is the coronal section more occipitally, trigone. But this is bad. And really, once the baby's had 3 weeks of antibiotics, look at the margins of the ventricles. They look healed. There's a little bit of ventriculitis there. And look at how the clot reorganizes itself. So there's a lot of healing. Even the meningeal enhancement that you can see is quite bright over here is much less bright over here. So actually using serial ultrasound can actually help you elucidate whether things are getting better or not. Naturally, if you start seeing things like this in a baby with a persisting CRP who's got really high infection markers, then really the question is, are your antibiotics not working because this is a cerebral abscess? And this, Maria asked a question, well, how do you recognize pus? So can you see the echogenicity of this material over here versus the echogenicity over here? So this is echogenic. This might be exudate. This is fairly dark. This is fluid. There's no exudate, and the fluid being dark looks like CSF. But when you look at the echogenicity of this material over here, this is really echogenic. This really makes you worry. This is not IVH bright. It's not as bright as the choroid. But this, in a baby who's not getting better, makes you worry that you have pus inside the ventricles. The only way you're going to find this out is either by doing a ventricular tap or demonstrating pus on CSF. So this baby basically had 14 days of treatment for E. coli meningitis. These were the ventricles before, and these are the ventricles after. They're dilated, it's worse, and you've got fairly echogenic material inside. So he's not gotten better. So basically, antibiotics either need changing, or really, some places will practice intraventricular instillation. I know that places where you can't cure these babies, eventually they end up with external ventricular devices. And we've had at least one case that I've seen in Southampton who ended up with an EVD because of problems like this. So in essence, this is a short summary of what infection looks like. I would really ask, for those of you who basically are working in India, for those of you who are working, over here, if you're able to share scans, because these are the most difficult scans in the UK. It's very difficult. I was just wondering, Maria, have you seen any cases of cerebral abscess in Milan?
Yes, Klebsiella. And then I've seen a case like this with ventriculitis and this hydrocephalus with a meningococcus B. And one was strep B.
Sure. Now, organisms give you organism-specific findings. Like if I talk about brain abscesses, like I said, Citrobacter fundii, Bacillus cereus tends to associate with abscesses. Multiple microabscesses are seen with Candida. Aspergillus can give you unilateral focal microabscesses. Common gram-positives that can give you abscesses give you very bad meningitis, Staph aureus. But very uncommon to find meningitis with staph capitis and staph epidermidis or coagulase negative staph. It's very uncommon. I've only ever seen one case in my entire career. So I am going to send you a few articles. I'm going to email them to you because they're not part of the drop. I can't share them with you as part of, they're not mentally approved. But yeah, with a small group of you, I'm quite happy to circulate it so that you can have a read of it. But it gives you a very nice overview of organism-specific effects on the brain that are visible in cranial ultrasound. Any questions? Do you have scans related to torch infections? Yes, we do, and we'll be doing them. So we're not covering torch infections today, viral infections. So we will show you herpes and CMV-related scans. That's great. I'm not going to take further time. You've spent enough time. I hope today's session was interesting. I hope the scans were interesting, thought-provoking. Look forward to seeing you next Thursday. From next Thursday onwards, we're going to basically start hydrocephalus. We'll be dealing with congenital first, then we'll talk about IVH, and then we'll talk about post-hemorrhagic hydrocephalus. But then we have a series of workshops which really are panel discussions of the different approaches that we take to management of hydrocephalus, because really there's no one way of unified standard. You'll really enjoy those workshops. So God bless you all. Have a good evening. Thank you very much for your attention.
Thank you, Alok. Very interesting. Thank you.
Thank you so much.